Hi and welcome back. Let's go over the cardiac conduction system and the dysrhythmias you're likely to see in your exams. The heart's electrical impulse starts at the sinoatrial node, the SA node. This is the natural pacemaker located in the right atrium. It generates the initial electrical signal that sets up the pace for the heart rate. The impulse then spreads across the atria, causing atrial contraction, and then travels through the atrioventricular node or the AV node, where it briefly slows down for about 0.12 seconds to 0.20 seconds, just to allow the ventricles time to relax and fill. From the AV node, the signal moves into the bundles of His, then splits into the right and left bundle branches, which carry the impulse down the intraventricular septum. Finally, the signal reaches the Purkinje fibers, which rapidly distribute the impulse through the ventricles, causing a strong, coordinated ventricular contraction. So, bottom line is that electrical happens before mechanical. The heart contracts only after the signal fires. The EKG machine will capture the electrical current moving across the heart and give us something we can see and work with. In a normal working heart and rhythm, one beat signal should look like this. One beat includes a P wave, QRS complex, and a T wave. P wave represents the atrial depolarization, the electrical current flowing through the atria. And once P wave appears, the two atria will contract. Remember, electrical comes before the mechanical. We always expect to see this little hump before every QRS complex. That means if it's not obvious that it's there, then there's some sort of dysrhythmia in the atrium. Could be atrial flutter if it looks like sawtooth, or AFib if it looks like a toddler trying to squiggle a line before the QRS complex happens. QRS complex represents the ventricular depolarization, that is, the electrical current flowing through the ventricles. When we see the QRS complex, the next thing we expect is that the ventricles should contract and you should feel the pulse when the ventricles contract. T wave represents ventricular repolarization. That means the resting phase for the ventricles. No electrical current should be flowing through the ventricles at this time. The muscles are trying to get back to their baseline and allow for the ventricles to fill in with blood from the atrium. If the T wave is very tall, almost as tall as the QRS, that's a peaked T wave. It's a sign of hyperkalemia, too much potassium in the patient's blood. If the T wave is inverted or upside down, possible ischemia in the heart muscles. And if the T wave is flat, we are worried about hypokalemia. The patient is low on the potassium. So, P wave represents atrial contraction, QRS ventricles contracting, and T wave ventricles relaxing. I have a question. When does the atria relax? Where is the wave for the atrial repolarization? Stay with me and I will answer this at the end of this video. Okay, let's talk about the PR interval. PR interval is the distance from the start of the P wave to the start of the QRS complex. PR interval represents the number of seconds it takes for the electrical current to move from the SA node to the atria until it gets to the AV node or the AV node conduction system. A normal range is 0.12 to 0.2 seconds. If this time is prolonged, then we suspect some blockage within the AV node conduction system. And this is where we start talking about heart blocks. So we expect some sort of delay from that's between 0.12 to 0.20 before the AV node can release the electrical signal to the ventricles. And this is because it's giving the ventricles a bit more time to finish relaxing or repolarizing and filling. Then it releases a signal to the ventricle muscle so that it gets depolarized and contraction should happen. However, prolonged PR interval is no bueno. It's signs of heart block. ST segment is usually unusual, but when it happens, we see it with ST elevation or ST depression. ST depression is a sign of ischemia of the heart muscles or hypokalemia or digoxin toxicity. So, if a patient is on digoxin and their EKG shows depressed or almost flattened T wave, check their potassium. Hypokalemia increases the risk for digoxin toxicity. ST elevation is usually suspected with myocardial cell death, or STEMI, ST elevation myocardial infarction. QT interval represents QRS, the time from the QRS complex to the T wave, the time it takes for the ventricles to contract and relax. Prolonged QT interval, we suspect hypomagnesemia or hypocalcemia, or the patient could be on some medications that can cause prolonged QT interval. For example, medications like amiodarone and some antibiotics. The issue with prolonged QT is that the patient can get into an arrhythmia called Torsades de points. It's a type of polymorphic VTAC. Solution here is to give that patient magnesium ASAP and hold the medications if patient is on a medication that prolongs QT interval. Let's go over how I usually calculate heart rate on an EKG strip. So I only mastered two ways, so that one is for when I have an EKG strip that is regular in rhythm, and the other one is if I have an EKG strip with an irregular rhythm. So if I look, how do I know that it's regular or irregular? So if the rhythm is regular, if there's a P wave before every QRS complex, and then there is a T wave at the end of the QRS complex. And then the distance between each QRS complex is the same, one after the other. Then this is definitely a regular rhythm. Once I know it's regular, I only take out of the whole EKG strip and make sure I only portion 6-second interval. So count 6 seconds, and then I use that. In most exams, they give you a 6-second EKG strip. So makes it easier because once you know that it's regular, you just count. So you just count the number of QRSs in the 6-second strip. Once you count the number of QRS complexes, you just multiply by 10. In this example, it's 9 QRS complexes, multiply by 10 to get 90 beats per minute. If I look at the distance between every QRS complex and they are different, one it takes longer than the other, one takes shorter time than the other between each other, so then I know that's irregular rhythm. So if I'm on irregular rhythm, then I use the 1500 divided by the number of small boxes between each R wave. So I go and count the number of boxes, small boxes, between my one R to the next one. So I usually do 3 in a row so that I can do an average. So in this example, I did one which the first one had 5 boxes between one R wave to the next, and then I divide it by 1500 to get 300 beats per minute. The next one, there were 10 boxes between the 2 R waves. I divide by 1500, get 150 beats per minute. And then the next one were 15 boxes, and I got 100 beats per minute. Then I just add 300 plus 150 plus 100, divide by 3, and that should be my answer if the rhythm is irregular. I hope this was helpful. For the dysrrhymias, I will cover what you need to know at this level. If you want to know more, of course, you're welcome to read further. Sinus tachycardia, very obvious. There is a P wave before every QRS complex. The only issue is the rate is higher than 100 beats per minute and is usually less than 130 beats per minute. Here, the issue is that we need to fix the cause for this tachycardia. It could be that the patient has a fever, they're in pain, maybe they are hypovolemic or they are bleeding. You can also give beta blockers if you're not able to address it. Or maybe some patients have hyperthyroidism, and this makes their heart just pace. So you give them beta blockers to slow down the heart. Sinus bradycardia. There is a P wave before every QRS complex. The only issue is the rate is less than 60 beats per minute. Fix the cause. It could be the patient is hypothermic, especially when they come out from the OR or they are on some sort of anesthesia or sedation medication, which can also slow down the heart. So patients could be on that, like propofol, or amiodarone. Hold it. Always hold the medication and notify the provider if their heart rate, if whatever medication they are on is slowing down their heart rate. Also, we have atropine if patient is symptomatic, or dopamine. So if you have a patient who's bradycardic and their blood pressure is now dropping, you could give them atropine, which is anticholinergic. It helps to block the parasympathetic stimulus going to the SA node. And this should help with boosting up the heart rate. Or you could give dopamine, which also stimulates sympathetic nervous system, which usually tells the sinoatrial node to increase the heart rate or to fire more often. Remember, some patients are naturally on the low side, like athletes. They always have this low heart rate and the body can live with it. They are in their 50s beats per minute. Or sometimes your patient is sleeping, because when you're sleeping, you're in the state of rest and digest. So your heart rate slows down, and some patients could go to 50s. When this happens, just check on your patient, make sure maybe they're sleeping. But of course, if the Brady is like crazy, like lower than 40, of course you are worried at this point, because you don't want your patient too Brady that they cannot support their perfusion of their organs. Moving on, there are three famous dysrhythmias of the atria or supraventricular that you will be tested on. Supraventricular just means dysrhythmias originating from the above the ventricles or from the atrium. Number one is a supraventricular tachycardia, SVT. The heart rate is so fast you don't even see the T wave. You literally just see um, the P wave and the QRS, PR and QRS. It's so fast. If patient is stable or asymptomatic, their blood pressure is good, they're not complaining of shortness of breath or feeling weird, you could suggest vagal maneuvers. It's invasive. Tell them to cough or bear down like they want to poop. And then you could do adenosine IV push. This medication, we usually give it very fast. You push fast and flash fast. The faster, the better. What I want to tell you about adenosine is that adenosine is very interesting because it will cardiovert the patient to sinus rhythm, but first it has to stop the heart, literally. And so you will see a flat line, a systole briefly on the monitor, and then this gives time for the SA node to pick up and start pacing the heart in a normal sinus rhythm. Of course, if the asystole persists, check for pulse on your patient, and if there's no pulse, it's a code blue and start CPR. So we suggest vagal maneuvers and giving adenosine if the patient is having SVT but they're stable, they're not symptomatic. Blood pressure is normal and they're not short of breath or anything. But if the patient is symptomatic, where their blood pressure is dropping, they feel funny or shortness of breath, we are going for electrical cardioversion. Medicate the patient before this happens. We usually use the AED machine, but don't forget to switch the setting to synchronized cardioversion, because you might shock your patient while they are on the unsynchronized mode, and this could lead to a lethal arrhythmia. This could send your patient to VFib. Always synchronize before you shock if you are doing electrical cardioversion. Of course, some patients have stubborn cells in the atria that won't stop firing even after the cardioversion. In such patients, they might benefit from ablation, where they catheterize through one artery or one vein. They get into the heart, and then they burn and they target and burn those cells and kill them, those cells that are trying to compete with the SA node, the heart pacemaker. The other two supraventricular dysrhythmias are atrial flutter and atrial fibrillation. Atrial flutter has a signature look that looks like a sawtooth wave before every QRS complex. And AFib is chaos in the atria. It looks like a toddler trying to squibble or draw P waves before each QRS complex. So it's kind of like chaotic. For both of them, the atria is quivering and not really contracting. The problem here is that there is increased risk of blood stasis in the atria and therefore clot formation. These clots can break off and move forward and get stuck in the tiny little blood vessels in the lungs, or causing pulmonary embolism, or in the brain causing embolic stroke. So patients with these two dysrhythmias are always put on anticoagulants like Eliquis or warfarin. Another thing is that since these crazy cells of the atria are firing signals and firing faster than the heart's pacemaker, some of the signals will get blocked by the AV node and won't get to the ventricles, and some will pass through. So if the patient has atrial flutter or atrial fibrillation and their heart rate is more than 100 beats per minute, the extra signals are probably reaching the ventricles, and this is called AFib RVR or AFib or A-flutter with RVR. RVR stands for Rapid Ventricular Response. So if you have AFib with a rapid ventricular response or an A-flutter with a rapid ventricular response, then we need to address this heart rate immediately. We have to slow down the heart because the ventricles might just go crazy too and cause VTAC. So patients with RVR will be on some sort of heart rate control medication to slow down the heart rate. If the patient is asymptomatic, blood pressure is stable, we can do medical cardioversion using medications like amiodarone, diltiazem to convert the rhythm to normal sinus. If the patient is symptomatic, we are seeing a drop in blood pressure, we go for electrical cardioversion. Again, always change the mode to synchronized cardioversion before you shock the patient. And preferably, please medicate your patient for pain before you electrocute them. It hurts. Now, we are entering into the red danger zone, the lethal arrhythmias. So, better pay attention. These are one of the common tested rhythms. Ventricular tachycardia or VTAC. VTAC may or may not have a pulse. Always check your patient. Of course, if they are talking to you, they probably have a pulse. And if they are not responding, try to wake them up, check their carotid pulse, if it might have a pulse or not. VTAC can look like monomorphic, whereby the shape is the same and the QRS is fat and regular. Or it might present in a polymorphic shape, different shapes, but the tip is sharp. This type of VTAC is called Torsades de points or twisting of the points in French. Usually a hint that the patient probably has a prolonged QT interval, which is caused by hypomagnesemia. So Torsades de points is usually caused by prolonged QT interval, or hypomagnesemia or hypocalcemia. Three things. Torsades de points is caused by 1, prolonged QT interval, number 2, hypomagnesemia, number 3, hypocalcemia. And then the third thing is the reason why a patient could have a prolonged QT interval is that they could be on a medication like amiodarone or some antibiotics which prolong the QT interval, or they could be hypomagnesemic. In VTAC, if the patient has a pulse and they are asymptomatic, blood pressure is stable, cardiovert them to sinus rhythm using medications like amiodarone, diltiazem. Of course, if amio is what caused it, the provider will definitely order something else. So always talk to the provider. Consult your provider before you continue or you proceed. And if the patient has low magnesium, you probably want to replace the magnesium to take them off of that Torsades de points. If the patient has a pulse but symptomatic, their blood pressure is dropping, they feel funny, shortness of breath, we're probably going to do synchronized cardioversion. And we use an AED machine, put the AED machine in a synchronized cardioversion mode. If the patient has no pulse, call code blue and begin CPR. Defibrillate as soon as possible. Put the AED in unsynchronized cardioversion mode. This is when the patient has no pulse, is when we shock the patient with unsynchronized cardioversion mode. Well, things are getting serious. We are moving to lethal, even more and more lethal rhythms. So ventricular fibrillation. When you hear fibrillation, just think of quivering or chaos. Fibrillation, chaos. So AFib was chaos in the atria. VFib is chaos in the ventricles. AFib, patient will definitely have a pulse, unless otherwise. VFib, this is a rhythm that has no pulse. It will never have a pulse. Don't let them trick you. VTAC may or may not have a pulse, but VFib never has a pulse. So we call code blue, begin CPR, and defibrillate as soon as possible because defibrillation is the goal here. It's what's going to shock and slap that chaotic waves going through, electrical current going through the ventricles and bring it back to sinus. CPR alone is not enough for the ventricular fibrillation. So in this case, we shock our patient with the mode and synchronized cardioversion. Fibrillation is quivering, like I said. It looks like a toddler trying to draw a straight line. Just to straighten things up, we have 4 lethal rhythms. 2 are shockable, that means you need to defibrillate ASAP, and the other 2 are non-shockable, so we do not defibrillate in that case. The 2 shockable rhythms include pulses, VTAC, and VFib. We shock because we have some substantial electrical activity flowing through the heart muscles and it's just chaotic and we need to shock it, slap it so it can get back to its normal sinus rhythm. The 2 non-shockable rhythms include pulseless electrical activity and asystole. PEA is a cardiac arrest rhythm where the monitor shows organized electrical activity but no pulse is generated. It looks like the patient is on sinus rhythm, but you try to wake them up, they are not responding. You check their pulse, they don't have a pulse. So the heart is not really responding. The heart's electrical system is working, but the mechanical pump has failed. There is a disconnection between the electrical and the mechanical. The SNOid is firing signals to contract, but the ventricles are not responding. PEA is a non-shockable rhythm. Defibrillation will not fix it because the muscles and the electrical current are speaking different languages, and so they're not on the same page. So you shocking them, the muscles will not even understand what you're telling them. So how do we fix it? We continue doing CPR. So if your patient is on PEA, continue with CPR, give epinephrine every 3 to 5 minutes, and also try to find the causes. What are the causes for your patient going into PEA? H's and T's. The other non-shockable rhythm is asystole. This is a complete absence of electrical activity in the heart, a true flatline on EKG. It's a form of cardiac arrest where the heart is not pumping at all. One of the most lethal rhythms with extremely low survival rate, if the patient gets into this rhythm, it's really hard to get them back. Asystole is non-shockable because there's no electrical current at all. Continue with CPR until the next rhythm check, whereby if it changes to, let's say, VFib or pulses VTAC, then you can shock them. If it changes to PEA, you just continue CPR. You cannot shock that one as well. Rule of thumb here, always confirm lead placements before calling it asystole or whatever type of dysrhythmia. Always assess the patient with any dysrhythmia. When you have don't just believe the monitor. Assess your patient. Make sure they are symptomatic or not symptomatic. Make sure they have a pulse or if they don't have a pulse. Check causes. Try to fix the causes behind the dysrhythmias. Is it because they are hypothermic, they are hypovolemic? Is it because they are acidotic? Try and fix the cause. Okay. Antiarrhythmic pharmacology. I have covered this content under the pharmacology playlist, so I suggest you go there if you want to go in depth and understand what different classes do and what you need to know about each class. But there are 4 classes, sodium channel blockers, beta blockers, calcium channel blockers, and potassium channel blockers. What I need you to know is that class 1 and class 3 can literally put your patient into a dysrhythmia. Even though they are antiarrhythmic medication, they can also cause dysrhythmias. So if you want more details, kindly go under the playlist for pharmacology where I cover this in depth. If I had asked, when does the P wave repolarize and why don't we see it captured in the EKG? The atria relaxes, but this happens exactly during the time the ventricles are contracting, during the QRS complex. And because the atria is small compared to the ventricular muscles, its wave is tiny and hidden behind the QRS complex. And so we never see it, but it's there. So the atria relaxation is present. The wave is there, but it's hidden behind the QRS complex. Thanks for staying through the video. If you found this content helpful, kindly subscribe, like and comment, share with your colleagues. Bye for now, and I'll see you on the next one.